here with the rest of the um, hematological conditions and patient care. Uh, I'm going to go ahead and start with anemia or pick up where we left off, which was anemia. So with anemia, it's not so much a medical condition or a diagnosis. It's actually a symptom of an underlying disease. So you may see in a report or in the chart that it says that the patient came in with anemia. Well, anemia is a symptom of another type of disease, which could be that they've cancer, and they're having anemia related to the chemo, or they have sickle cell, and so they're coming in not only for pain, but also for anemia, which is reduction of the number of red blood cells, especially the hemoglobin and hematocrit. So that's the general impairment of the body's ability for gas exchange. The body's capability of carrying oxygen becomes less. Therefore, you have less oxygen that's transported to the tissues and the organs. And it creates static demand and affects the pulmonary and hematology systems. Meaning when there's low oxygen, then other systems have to try to compensate. And that puts a lot more demand, and these systems have to work even harder. Anyway, so as far as causes, there are anemia related to dietary issues. There's anemia related to possibly genetic. There's bone marrow diseases that can cause anemia, and one that pretty known to us is excessive bleeding. Cues and symptoms related to anemia. And so we'll see it through some of the different systems, like, for example, with the skin, the person may not look great. They may look tired. They may have some pallor or some paleness. They may even look a little ashy color. So that's definitely an easy way to pick up that a person's having anemia is how their skin looks. Not only that, the skin is cool to touch. When you touch them, they feel cool. They may complain that they are cold. So that's, as far as skin, those are some of the symptoms that we'll see. Cardiovascular wise, because there is that decreased oxygen being circulated, the heart has to pick up and pump more, which increases the heart rate in order to get more blood, and then with that red blood cells, and then with that, the oxygen that all the body tissues and all the body organs need. As far as respiratory, we'll see the O2 sats will be low. They will be very tired, and they will get breathless upon exertion, and that can be just maybe walking from the living room to the bathroom, or walking to the mailbox, or even going up a flight of stairs. GI symptoms, patient may have some issues with nausea. They may have weight loss issues. They may have diarrhea or anorexia, and they may have something called glossitis, which involves the mouth and the tongue. And we'll see that with a vitamin B12 type of anemia. Musculoskeleton, they will have difficulty walking. As far as neuro, they will again be fatigued, will have really reduced energy levels, and they may feel some numbness of their hands and feet. Types of anemia, I'm going to cover them, pretty much all of them except the glucose 6 phosphate dehydrogenase deficiency, or G6PD. With iron deficiency anemia, as it says, it's the body is deficient in the iron, and iron is important for red blood cells. This is very common, especially among premenopausal women. Deficiency can be related to blood loss, as in when we see with adolescents with the onset of their menses and with their monthly periods, where some girls or some young ladies lose a lot of blood, therefore they're losing that iron. Iron deficiency anemia can also be caused by deficits in iron intake in their diet. Also, alcoholism can cause iron deficiency, partial gastrectomy, where they take out half of the stomach. Pregnancy is also a reason, because all the resources from the body is now going through another person, and so that causes anemia. And for most of our pregnant women, they are put on iron and folic acid. And also infection can cause iron deficiency anemia. B12 deficiency is also called cobalamin deficiency. It's a dietary deficiency, and it's related to the failure of the gut to absorb vitamin B12 and also folate, because it's lacking what is known as the intrinsic factor. And with that, with the intrinsic factor missing, that's what we call pernicious anemia. Also, partial gastrectomy, as I mentioned, with iron deficiency, increase in alcohol, and also taking some types of medication like your oral anti-contraceptives, some of your anticonvulsive or anti-seizure medicines, and some of your cancer medications. There's another type of anemia that I'm going to include. It's called megaloblastic anemia. And this is when the bone marrow produces oversized red blood cells. And so with somebody with megaloblastic anemia, I mean, these are gigantic red blood cells, and they're not performing the function that they need to, because they're just too big. And so you may see somebody pale, as I mentioned earlier, glossitis, fatigue, weight loss, some jaundice as well, and some numbness to the hands and feet. Folic acid deficiency, very similar to B12, with the exception that with folic acid deficiency, you will not see the paresthesia or the numbness of the hands and feet. Folic acid is related to poor nutrition, poor intake of your green leafy vegetables, liver, citrus. It can also be related to what we call a malabsorption syndrome, which for another reason other than missing the intrinsic factor, the vitamin cannot be absorbed in the gut. And also medications, as I mentioned earlier, the anticonvulsives, the oral contraceptives. Aplastic anemia, what happens with aplastic anemia is that, or we can relate it as bone marrow disease. The bone marrow is suppressed, it fails to produce enough blood cells. And we're talking about multiple blood cells. We're talking about white blood cells, platelets, red blood cells, all that. Or there could be a destruction of the stem cells in bone marrow, and this can be related to either exposure to radiation, somebody that has cancer that is radiation therapy. This can be an adverse effect of that, as well as somebody who is exposed to radiation, or in a place where they deal with radiation. the treatment would be blood transfusion, maybe a bone marrow stimulant, etc. Acquired autoimmune hemolytic anemia. What happens here is there's malfunction of the immune system, and because the immune system is there's a function, the immune system is just going to go out and destroy the red cells because the body is perceiving red blood cells for our body, and therefore is going to produce the white cell count. So we'll see the depletion of blood cells, especially red red blood cells. Anemia, chronic disease. This is caused by inflammation. That is caused by chronic diseases, disorders like cancer, like kidney failure, or chronic kidney disease, or failure, autoimmune. So, especially with older adults, that they have a lot of chronic diseases. These chronic diseases will cause inflammation, which will decrease the production of red blood cells, or increase the lifespan of red blood cells, or it can also alter the way the body uses, for example, iron. Related to blood loss, this is obviously, as it says, is that results from excessive bleeding, something is hemorrhaging, something has decreased hematocrit. Or the different types of anemia, especially our iron deficiency, or nutritional deficiency anemia, starting with iron deficiency. So increase oral intake of iron either by food, and some of the foods that are rich in iron are beef, lamb, turkey, liver, tuna, sardines, shrimp, dark green leafy vegetables, broccoli, white and wheat bread, oatmeal, oat cereals, bran cereals, raisins, dates, strawberries, prunes, lentils, kidney beans, and garbanzos. Now, this is not an all-inclusive list. Many of what we eat has as iron, and then the use of iron supplements, ferrous gluconate, ferrous sulfate. There's many iron supplements out in the market, and so when you study anemia in your patho-pharm, then you'll learn about the different iron supplements and what are the nurses' responsibilities in educating the patient when they're going home on these types of medication. Now, vitamin B12, pretty much the same thing, increasing the foods that are rich in vitamin B12. And some of those are very similar to the iron deficiency ones, like your liver, or basically your organ meats, clams, sardines, beef, 4 to 5 cereals, tuna, trout, salmon, 4 to 5 non-dairy milk, cow's milk, and eggs. And then also they can receive injections of vitamin B12, that is IM, and they can also get oral supplements for that, nasal sprays, and some sublingual cobalamin. Folic acid, again, making sure that they are taking foods that are rich in folic acid as well as vitamin B12. They kind of go together, vitamin B12 and folic acid. Now, for folic acid, some of the foods: dark green leafy vegetables, beans, peanuts, sunflower seeds, fresh fruit, fresh juices, fruit juices, whole grains, liver, and aplastic anemia. It's going to depend on what's causing the anemia. Remember, I mentioned that it related to, for some reason, the bone marrow has stopped producing producing red blood cells, or there's a destruction of the stem cells in the bone marrow. So depending on what the cause is, they will treat as such. Some other interventions is if this is drug induced, because sometimes medications, especially cancer medications, can induce this the bone marrow to stop producing red blood cells. So if whatever medicine it is, that medicine should be discontinued. Blood transfusion is another intervention for aplastic anemia. Also immunosuppressive therapy, and what happens with the immunosuppressant therapy is that it prevents the immune system from attacking the bone marrow, allowing the bone marrow stem cells to grow and to produce more blood cells. And bone marrow stimulants, for example, epoetin alpha is a bone marrow stimulant that is given, and that helps with increasing the production of blood cells in the bone marrow. Anemia, remember that hemolytic anemia is the immune system is malfunctioning and causing the destructions of red blood cells, or the body perceiving red blood cells as a foreign body and develops antibodies to kill these red blood cells. So depending on what's causing it is what the treatment's going to be. The use of steroids is an important therapy in hemolytic anemia, and if steroids fail, then splenectomy. Now, with all of these interventions, as far as nursing, if it's related to medication, knowing about the medication, what are the side effects, picking up on those side effects, educating the patient on those side effects. If they need blood transfusion, which we will discuss in a few minutes, your responsibilities in regards to blood transfusion. If it's related to nutritional needs, you can always get the dietitian involved, and so that when the patient gets their food, they'll get food that are rich in these nutrients that are missing. Now, anemia of chronic disease, as I mentioned earlier, with our elderly, they have all these chronic diseases which can cause anemia. So addressing what exactly or which chronic disease is causing the anemia, then that would be corrected. They're gonna need something that is going to stimulate erythropoiesis, which is the formation of the blood cells, and I talked a little bit about that with the epoetin alpha, which stimulates the bone marrow. And anemia related to blood loss, what is causing the blood loss, first of all, and correct that as such. Let me give you an example. Let's just take a really simple example. A young female who have increased bleeding during her menses, that is causing this blood loss. What they can do in some instances is place the prescribed birth control, oral contraceptive, and that will help control some of that bleeding. Iron supplements, vitamin B12 supplements, if all that is related to the blood loss, and transfusions. That you may see is what we call thrombocytopenic purpura, and this is related to platelets. And so there is an issue with either destruction of the platelets, or there is a decreased amount of platelets, or the platelets are not being produced, and this is going to cause thrombocytopenia. The important thing to know with any of these thrombocytopenia types is that you're going to be observing for bleeding because it is the platelets that help with blood coagulation. So always keep that in mind. All right, so there's different types of thrombocytopenia purpura. The first one is called idiopathic or immune thrombocytopenia purpura. This one is an autoimmune disorder in which the lifespan of the platelet is decreased by antiplatelet antibodies, meaning that the body senses the platelets as a foreign body, and so these antibodies they start working on decreasing or destroying these platelets. So there's a lower number of platelets. Not only that, but platelets and your blood cells, they have a lifespan. You know, they last every 28 days or something like that. So with the ITP, either the amount or the duration of their lifespan decreases because the body senses the platelets as a foreign body. Now, this can result in severe hemorrhage. So again, for thrombocytopenia, we're looking for bleeding. Now, risk factors for this particular type of thrombocytopenia, it's more prevalent. It can be more prevalent in females, ages 20 to 50. Medications can cause this. Some viruses can cause this condition, for example, HIV and hepatitis C. Any other autoimmune disorders can also cause this thrombocytopenia. Signs and symptoms, easily bruising. You're going to see purpura, which is not petechiae like those little purple dots, but purpura is more an area that looks purplish. Labs for this is going to be your hemoglobin, hematocrit. Obviously, they're going to check platelets, and they're going to do a typing cross for possible blood transfusion. And so some of the treatments for this can be the use of corticosteroids, immunosuppressants, removing the splenectomy, and if the bleeding is severe, then they'll do the blood transfusion. The second type of thrombocytopenia is called thrombotic thrombocytopenia purpura, or TTP. What happens here is that the platelets, they abnormally clump together, which results in not enough of the platelets circulating, okay, in the blood. And not only that, these clumps can get into the small capillaries and can clog or cause an obstruction. And there's no blood, there's no circulation, there's no oxygen, etc. This TTP can be acquired or inherited. Risk factors are other autoimmune diseases. It's kind of amazing how our body is such a great thing, but our body, when they sense that something is not what they sense, is not normal, then it kind of turns against them. Labs, CBC, and typing cross for possible blood transfusion. Signs and symptoms: pallor, weakness. Patient can have fever, can have that purpura in different areas of the body. There can be red blood cells in the urine. And so the treatment is immunosuppressants, maybe some antiplatelets to kind of decrease the platelets clumping together. Some of those antiplatelet medications include like aspirin and clopidogrel. Also for treatment can be plasma exchange. For the HIT, which refers to heparin-induced thrombocytopenia. What happens here that there's an unexplained drop in platelets. And we see that as an adverse reaction to heparin therapy. Let's say you have a patient that comes in and they have a DVT or deep vein thrombosis. For the treatment of that is heparin IV, and then they'll switch to other anticoagulants, but heparin, because heparin is short-acting, it's quick, and that's what the treatment is for blood clots. So this is an adverse reaction to heparin. Risk factors, obviously the exposure of unfractionated heparin, maybe female, that's another risk factor. And then even recovering from receiving heparin at 2 weeks. So not only can it happen while they're on it in the hospital, it can happen after they've had the course of therapy and they've been discharged home. So the treatment basically is to stop the heparin. Okay, stop the heparin and try them on another type of anticoagulant. Labs that you're going to be monitoring is the ProTime and INR. Signs and symptoms, the patient may have some mild pain, some mild redness, maybe some swelling of the extremities. But whenever you have somebody that's on any type of medication, always tell them to let you know when things don't feel right. Because sometimes they may not know what exactly is, but the fact that they're saying that just something just not feels right is worth investigating. Condition, especially anemia, the thrombocytopenia types of condition, even your sickle cell, and even your HIV patients may at some point require blood transfusion. And so there's different types of blood products that the person can receive. One is transfusion of just red blood cells. And so what happens is that whatever donors they have from the whole blood, which has everything, your white cells, your red blood cells, your platelets, all that, then they'll extract only the red blood cells, and that's what's being transfused. For anemia, for blood disorders, platelets, you can transfuse only platelets. And we have somebody who has a low count, who is actively bleeding, and we know it is related to low platelets. They will receive platelets. Plasma transfusion. So with the plasma, you receive immunoglobulins, which are your antibodies in your body, as well as some clotting factors. And we usually refer this to fresh frozen plasma. This will provide temporary immunity. This is for severe burns, infection, liver failure. And so that is a blood product that can be given. Then you have the white blood cells transfusion, and that's something that is given rarely, if any, to patients that have really, really low white blood count, especially your neutropenic patients. Massive transfusion protocol. As the type implies, we're talking about infusing a lot of blood. And this can be due to major surgery, trauma, and obstetric hemorrhage. And this is the administration of 10 or possibly more units of whole blood or packed red blood cells over a 24-hour period. And what this does is that it restores a volume, blood volume, it restores clotting ability, and most important of all, that increases the oxygen carrying capability. And so there are different protocols, and each institution will have its own protocol. And what the protocol kind of involves is the ratio of the different types of blood products that you're going to be infusing. Like, for example, there may be an institution that does a protocol that is one per one, meaning 1 unit of our blood cells given with 1 unit of packed fresh frozen plasma and with 1 unit of platelets. So those are things that may vary depending on the institution that you are working. But the important thing to know is, what is your massive transfusion protocol? Now, I suspect that if this probably will happen like in the emergency room when you're having trauma coming in, and so they would be ready for that. I don't believe that on a particular unit you would have something like that unless they can't go to the ER, and so it's going to maybe perform on the unit. But again, check on your policy to see what areas in the hospital can a massive transfusion protocol take place. And go over the responsibilities for the nurses pre, during, and post transfusion. And you're going to be giving a lot of blood or blood products during your career as a nurse. You can work for a blood bank, you can work in a dialysis unit, and they usually give a lot of blood, or on a, let's say, an ortho unit. Patients that have ortho surgeries, they lose a lot of blood, and more times than not, they require transfusion because their hemoglobin hematocrit are low. So what are some of the responsibilities before a transfusion? Obviously, there's going to be an order that says transfuse 2 units of packed red blood cells, and it needs to be specific. How many units over how many hours? Because blood there's time sensitive with blood products. They have to be infused within a certain amount of time. So review your policy at your institution. It will have a very detailed explanation, and it will list all the steps needed for safe blood transfusion on the unit or wherever in the hospital. You want to verify the orders with another RN. Usually what they'll do is if there's not any blood, or if the patient has not been tested for type and cross, meaning making sure that depending on their blood type that they get the correct type of blood. So they may have what they call a type and cross, or maybe a type and hold, meaning that they'll type them, but they'll hold off on the cross matching unless when if they go to surgery and they need it, then at that point they will do that. So what usually happens is that you go down to the blood bank and you are going to pick up the blood or the blood product, because it can be platelets, it can be fresh frozen plasma, it can be whole blood, or it can be red blood cells. And so when you go to the blood bank, you're going to have information on your patient, especially medical records, name, age, plus you're going to be double checking with the blood bank, making sure that it's the right blood, the right compatibility. So there is a process for that, but it is checked and double checked. then once you come to the unit, then you'll set the patient up for the transfusion. I would recommend before you even go pick up the blood is that you need to do some set of pre-transfusion vital signs. And the reason why is because if there's any issues like, let's say, high blood pressure or there is a fever, you want to make sure that you notify the physician and get orders to treat that before you go get the blood, because once the blood is out of the blood bank, you only have a certain amount of time to take it upstairs and to infuse it. All right. So you got your vital signs, patient looks good, there's no fever, there's no complaints. And then another thing that's very important, you want to make sure that the patient has a good IV access. And I guess the minimum is a 20 gauge. The best is an 18 gauge needle. Anything less than a 20, you may have difficulty, although nowadays, you can infuse them via a pump, which when I first started nursing, they didn't have that, and we had to do it manually and count the drips and all that. Okay, so once you bring the bag to the unit, then you have to check it again with another nurse. Okay, there's a tag. You check the compatibility. Again, you're doing your checks with your patient. You want to check the blood for expiration, day and time with the other RN. You want to look at the blood for any type of cloudiness, discoloration, bubbles. So that's something that you need to check. And there's tubing, blood transfusion tubing that you will have already set up. You usually set it up with one spike into a normal saline, and that's the only type of fluid that you can run a transfusion with is normal saline, not D5, not lactator ringers, it's normal saline. And then you hook the other IV, the blood into the other spike. All right, and then let's continue on to what happens. Earlier, there's going to be a type of tubing that you're going to use for running your blood. So the appropriate tubing, filtered tubing, because that helps remove whatever contaminants that the blood may have. Again, unless directed otherwise, infuse the blood products with only normal saline, because other IVs may cause hemolysis or breakdown of the red blood cells. Once you have the patient connected and you have the blood going in, you want to stay with the patient for the first 15 or 30 minutes, because that is kind of like the time frame that if the patient's going to have a complication or a blood transfusion effect, that would be the time. So sit with the patient, do some charting, talk to the patient, ask them how they're feeling, and then between the 15 and 30, they're doing well, then you can, so he'll be doing fine, but that does not mean that he'll not have they may have a reaction later on. But what's important is that 15 to 30 minutes, you want to be able to be there with the patient, get to know your patient better, talk to them. And, the goal is that the patient gets the blood transfusion safely without any type of complication. Always make sure that you're running it at the right amount, because you don't want to stimulate or any fluid overload. Okay, and then with the blood transfusion protocol, there are vital signs that are taken at different intervals. And so make sure that you're following your hospital policy as to how often you are doing the vital signs, how often you're checking to make sure that the blood is dripping, making sure that your site looks good, okay, and the patient is comfortable and nothing else is happening. blood transfusion reactions. It can even happen within 24 hours of the transfusion. The patient can even have a delay reaction that can take place up to 30 days. And the patient may develop severe fever, chills. They may have an allergic response to it. So again, just making sure that that you are monitoring your patient. To go over what is autologous blood transfusion, I wanted to kind of step back a little bit so that you are aware of what to look for with a blood transfusion. I talked about that a little bit. The patient may be complaining of itching, hives. They may start having a fever. Hence, that's why it's important to get those vital signs at the intervals that are ordered. Fever, chills, nausea. They may have chest pain. They may have lower back pain, and they may have dark urine. So if the patient is having a blood transfusion reaction, the first thing you need to do is to stop the transfusion. Important information, you're going to stop the transfusion. And then you're going to remove all the blood tubing and put it in a bag and return it to the blood bank. You're going to call rapid response to come into the room. You're going to make sure take all that what I said, the tubing, and you're going to flush the IV with normal saline if they don't have another access. If not, you want to try another IV, apply oxygen. There is your protocol or your policy will call for applying oxygen, giving IV diphenhydramine, which is Benadryl, and if it comes to that the patient's having a massive reaction that requires CPR, again, doing CPR, and this patient may have to go to the unit and be monitored. So important, patient complains that something doesn't feel right, and they're having complaints of hives. You see hives and redness, and they have a fever. Stop it. Okay, stop that transfusion. Okay, moving on to autologous blood transfusion. This is something that's really neat because it is the patient receiving its own blood. Okay, receiving its own blood. This is something that can be done pre-op. Patient goes in, they donate their blood, and the blood can be given during the surgery or can be given after surgery, and it's going to depend on their blood count, their H&H. I've seen this a lot in orthopedic surgery, where the patient goes in for their pre-op and then they donate their blood. And what I have seen is that after they've come back from surgery, they look at the H&H, and if the H&H is low, then they will order the blood to be reinfused into the patient. And there's special device that collects, filters, and draws the blood into a bag, and then it gets reinfused into the patient. And there is a time limitation with this as well. So follow your hospital's policy. And let me know if you have any questions.